Welcome to the second part of the presentation on diabetic macular edema. In this we'll be discussing the management. So before discussing the management, we need to know the natural history of DME. So this was given by the ETDRS study. In this they had seen that the rate of moderate visual loss, that is greater than 15 letters, was 8% per year for non-treated eyes. The rate of visual loss also increased with worse presenting visual acuity, and the rate of visual loss increased with the severity of diabetic retinopathy at presentation. So basically, if we do not treat eyes with diabetic macular edema, then the visual loss is greater than those in which we treat. So now coming to the different modalities of treatment which are available to treat diabetic macular edema. In this we mainly have laser photocoagulation, then intravitreal injections and vitrectomy. Laser photocoagulation can be of two types, that is conventional laser, and it can also be subthreshold laser. Then the second option that we have are intravitreal injections. These can be anti-vascular endothelial growth factor, or these could also be steroids. And the last option is vitrectomy, which is surgical. Firstly, coming to conventional laser photocoagulation, this can be of two types. One is focal and the other type is grid. In focal, we target the individual leaking microaneurysms in an area between 500 micron to 3000 microns from the center of the macula. In modified grid, we target all areas of retinal thickening or diffuse leakage between 500 to 3000 microns from the center of the macula. In how modified grid differs from grid is that in modified grid, the papillomacular bundle is spared. In both of these modalities, we use 532 nanometer ND-YAG or argon green laser. So now coming to subthreshold laser. The main difference between subthreshold laser and conventional laser is that in subthreshold laser, the laser pulses are given at subthreshold levels in the form of micropulses, which are shorter than the thermal relaxation time of the RPE. Because of this, there is selective damage to the RPE and the photoreceptors and choriocapillaries are spared. Now coming to the intravitreal injections, firstly the anti-vascular endothelial growth factor injections. These are of several types. For example, aflibercept, it is a VEGF receptor 1 to Fc fusion protein. Ranibizumab is a Fab fragment, and bevacizumab is a full body antibody. And the newest one is brolucizumab. It is a single chain antibody fragment. The other form of intravitreal injections are the steroids. What they do is inhibit production and release of VEGF. They also prevent loss of endothelial tight junctions, and they reduce inflammatory mediators of diabetic macular edema. Finally, coming to the surgical management, it is vitrectomy. What theoretically it does is that it increases oxygen tension of the inner retina by improving fluid currents, and it also releases the tractional component in vitreomacular traction, thereby relieving your diabetic macular edema. So as we know from our previous presentation, diabetic macular edema can be classified into either center involving or center non-involving. So let us come into center non-involving first. So center non-involving diabetic macular edema can either be observed or we can perform laser photocoagulation. So in this case example, we can see that the best corrected visual acuity is 6/6. In the fundus image, we have a dull foveal reflex surrounded by hard exudates, some retinal hemorrhages. In the OCT scan, we can see that there are a few hard exudates, but the fovea seems to be intact. So in this case, what are we going to do? So according to the guidelines, non-center involving DME which has good vision, either 6/6 or 6/9, can be observed. And non-center involving DME with BCVA which is worse than 6/9 can be treated with macular laser if it meets the clinically significant macular edema criteria. So when it is non-center involving DME, if there is focal leakage, we can perform focal laser, or if there is diffuse leakage, then we can go ahead with modified grid laser. How about the newer modality, that is your subthreshold laser? Is it equal to conventional laser? So this study, which was also known as the Diamond trial, it compared subthreshold laser to conventional laser, and in this it found that subthreshold laser was non-inferior and equivalent to standard laser for central retinal thickness of less than 400 microns. However, there were more number of laser treatments required in case of subthreshold laser in comparison to conventional photocoagulation. So what about cases in which initially it was center involving DME. However, after intravitreal injections, it became non-center involving DME. So according to the guidelines, if the vision is good, that is 6/9 or better, then we can observe. However, if the vision is worse, that is less than 6/9, then macular laser can be considered. And if it fails, then we can always go ahead with anti-VEGF injections. In this case example, we can see that the best corrected visual acuity is 6/9. However, in the fundus, we can see the foveal reflex is dull. There are a number of hard exudates surrounding the fovea. There are retinal hemorrhages. In the OCT scan, we can also see that there is intraretinal fluid. There is also neurosensory detachment. There are also hyperreflective dots. So what do we do in this case? So in such cases, we need to consider the visual acuity. If the visual acuity is better than 6/9, then according to the drcr.net protocol V, we can go ahead with observation. Since in this study, what they found was that amongst eyes that had center involving DME and good visual acuity, there was no significant difference in vision loss at 2 years, whether these eyes were initially managed with aflibercept or with laser photocoagulation or observation. And actually, if aflibercept was used in such cases, the visual acuity worsened. However, when considering center involving DME, we also need to take into account another factor, that is the central retinal thickness. So in this example, according to the UK NICE guidelines, the central retinal thickness, if it is more than 400 microns, then it qualifies for treatment. So in case of treatment-naive center involving diabetic macular edema with visual acuity less than 6/9, always the first line of therapy is intravitreal anti-VEGFs. Intravitreal anti-VEGF injections are initially given monthly as loading doses for 4 to 6 months. However, after this duration, these cases are observed whether there is any improvement or not, and based on that, either treatment can be given or it can be put on hold. The alternative mode of treatment is the treat and extend, in which we gradually increase the duration or the interval between injections at a fixed duration. So all of these information regarding anti-VEGF injection have been given by a number of landmark trials. So the first trial that gave us which anti-VEGF to use was the Rise and Ride trial. And in Rise and Ride trial, basically they compared ranibizumab injections to sham injections or placebo therapy, and they found that ranibizumab gave better visual acuity at the end of the treatment, and also higher reduction in central retinal thickness. The other studies involving ranibizumab were the RESTORE study. In the RESTORE study, ranibizumab monotherapy or combined with laser was compared with laser monotherapy for diabetic macular edema. In this, they found that ranibizumab monotherapy and combined with laser provided superior visual acuity gain over standard laser in patients with visual impairment due to diabetic macular edema. Another study compared intravitreal ranibizumab with prompt versus deferred laser treatment, and they found that the visual acuity was better in cases where the laser was deferred rather than in those cases where the laser was given in a prompt manner. That means we should try to avoid laser as much as we can in our cases. The other landmark trial is the VIVID and VISTA study. In this study basically compared aflibercept versus placebo or sham injections, and they found that aflibercept had better visual acuity gains and also a higher reduction in central retinal thickness as compared to sham injections. So let us look at another case example. In this case, we can see that there is a center involving diabetic macular edema with a BCVA of 6/12. And in this case, we have the same center involving diabetic macular edema. However, in this case, the BCVA is 6/24. So how do we decide which injection we should go ahead with when we have so many options? So a study in the drcr.net of protocol T initially compared aflibercept versus bevacizumab versus ranibizumab for diabetic macular edema. And in this case, they found that overall aflibercept, bevacizumab and ranibizumab had more or less equal visual gains. However, when the visual acuity was less than 20/50 or worse, then aflibercept had a better visual acuity gains. Also, in the central retinal thickness, in cases where the visual acuity was 20/50 or worse, then aflibercept had a better reduction in central retinal thickness. So basically what drcr.net protocol T tells us is that if the visual acuity is between 20/32 to 20/40, then we can choose either ranibizumab or aflibercept in such cases, and both of these will give us equal results. However, if the visual acuity is 20/50 or worse, then aflibercept has been seen to give better visual acuity and central retinal thickness reduction outcomes. The newest clinical trial in this anti-VEGF group of drugs which has taken place is the Castrol and Kite trial. In the Castrol and Kite trial, it was shown that brolucizumab had good visual acuity gains and also better central retinal thickness reduction in diabetic macular edema when compared with placebo or sham injections. So let us take another example. In this case, we have a center involving diabetic macular edema, and the BCVA in this patient is 6/36, and the patient has a history of multiple anti-VEGF injections. Basically, this patient is a non-responder to anti-VEGF injections. So what should we do in such cases? So what the guidelines tell us is that if there is persistent DME and the BCVA is less than 6/12, then we should perform an anti-VEGF switch. So if initially we were using bevacizumab, then we should either switch it to ranibizumab or aflibercept. However, if we were initially using ranibizumab, then we should switch it to aflibercept. So when do we perform this switch? So there are no clear guidelines on this, but according to these guidelines, what most clinicians switch anti-VEGF injections is after 2 to 3 injections, and they switch to steroids after usually 6 injections of anti-VEGFs. So let us come to another example. So in this case, the BCVA is 6/36. In this fundus fluorescein angiography image, we can see that there is enlargement of the FAZ, that is the foveal avascular zone. And in the corresponding OCT, we can see there are multiple intraretinal cystic changes. So this case basically shows a person with macular ischemia. So in such cases, according to the guidelines, we should treat them with anti-VEGF and steroids, and laser is contraindicated in such cases. And also we need to counsel the patient in such cases that the visual acuity gains even after treatment with anti-VEGF is not going to be quite good, as there is ischemia. So after we have started giving anti-VEGF injections, when do we decide to stop the treatment? So basically we need to look at two parameters, that is the central retinal thickness and the visual acuity gain. So if there is less than 10% decrease in central retinal thickness or there is less than 1 line improvement in Snellen's acuity after the last anti-VEGF injection, then we should stop the anti-VEGF treatment and counsel the patient that there might not be further improvement in visual acuity even after further anti-VEGF injections, and the patient can be put under observation. So after anti-VEGF injections, let us come to the intravitreal steroids. So the first study that gave us evidence that intravitreal steroids are useful in diabetic macular edema was the MEAD study. In this study, dexamethasone intravitreal implants were studied for diabetic macular edema, and they were compared to placebo or sham injections. And they found that there was better visual acuity gain and more reduction in central retinal thickness in cases of intravitreal dexamethasone implant. So another study was done in which they compared bevacizumab with intravitreal dexamethasone implant for diabetic macular edema, and this was the BEVOR-DEX study. So in this, they found that dexamethasone implants for DME had better visual acuity gains and also a higher reduction in central retinal thickness in comparison to bevacizumab. And also the number of injections were less in case of dexamethasone implants for diabetic macular edema than bevacizumab injections. So now, having learned all of that, what if we add a steroid implant with an anti-VEGF injection? How would it perform in case of diabetic macular edema? So a study was done, and it was the drcr.net protocol U. So in this, they studied the effect of adding dexamethasone to ranibizumab treatment in patients with persistent diabetic macular edema. So what they found was that addition of dexamethasone did not improve visual acuity more than ranibizumab monotherapy. So basically, the addition of intravitreal steroids to already continued anti-VEGF therapy does not significantly improve visual acuity. So these intravitreal steroids are in a way effective. However, they may have a number of complications. So the most common complication associated with dexamethasone implant is the rise in intraocular pressure. So this study, the MEAD study, showed that in cases of placebo, there was not much difference in the rise in intraocular pressure. However, in case of dexamethasone implant, there was an increase in intraocular pressure. So another study was performed in which they studied the safety after giving 6,000 intravitreal dexamethasone implants, and in this they found that the rise in intraocular pressure was present in 20% of the cases. However, in 27.1% of the cases, the increase in IOP was more than 10 mmHg from the baseline. In only 23.3%, the rise in IOP was more than 25 mmHg, and in a very few 6.2% cases, the rise in IOP was more than 35 mmHg. Basically, it showed that the steroid responders in such cases of intravitreal dexamethasone implant, very rarely do they have an IOP more than 35 mmHg, and most of these cases could be well controlled with anti-glaucoma medications. Another intravitreal steroid which can be used in cases of diabetic macular edema is the fluocinolone acetonide. And in the FAME study, they found out that fluocinolone acetonide implants are useful in cases of diabetic macular edema with good reduction in central retinal thickness and better visual acuity gains in comparison to sham injections. So when do we decide to switch to steroids? So according to the guidelines, if we see that the patient has a difficulty in maintaining regular follow-ups, then we might choose to switch to steroids. Also, in pseudophakic patients where we have reached the plateau response and in which there is persistent intraretinal fluid or the visual acuity is less than 6/12, then in such cases we can decide to switch to steroids. Also, in cases where they need a cataract surgery and they also have a persistent diabetic macular edema, so in such cases also we can switch to steroids. Another important reason to switch to steroids could be the occurrence of systemic vascular events while the patient was on anti-vascular endothelial growth factors. In cases where there is extensive hard exudates or there are hyperreflective dots on OCT scans, in those cases also we can switch to steroids. And in cases where we have performed surgery such as vitrectomy, so those cases also are good candidates for the use of intravitreal steroids. So now coming to cases where there is persistent diabetic macular edema, is there any role for laser? So according to the guidelines, if there is persistent DME with visible microaneurysms, then we can go ahead with laser. And also in cases where there is persistent diabetic macular edema and we want to switch to steroids, however, switching to steroids is contraindicated due to the patient having glaucoma, or if the patient is a young phakic patient. So in such cases we can go ahead with laser. Now finally, coming to the surgical treatment of diabetic macular edema. So there was a meta-analysis done, and in this they found that pars plana vitrectomy in diabetic macular edema worked only in a very select group of patients. And also in this study they found that the visual gains did not vary significantly from that of standard care, that is the use of laser photocoagulation and anti-VEGF injections. So basically vitrectomy is useful in diabetic macular edema only when there is persistent diabetic macular edema with the presence of vitreomacular traction. It is never a first choice, and also the structural improvement is good, but the visual acuity gains are not better in comparison to standard care. So in this case example, let us revise what we have learned. The best corrected visual acuity is 6/36. The patient has persistent diabetic macular edema and is a post-vitrectomized eye. So in this case, how are we going to treat it? So as I had mentioned before, we can go ahead with intravitreal steroid implant. So what does the guidelines say? So there is limited data on what agent we should be using in such cases. However, studies have shown that ranibizumab can have some effect, although the half-life decreases due to the change in the fluid currents in the vitreous cavity after vitrectomy. So anti-VEGFs might still have a role. However, we would always prefer to give an intravitreal steroid if it is not contraindicated in such cases. So coming to another example. So here we have best corrected visual acuity of 6/36. There is center involving diabetic macular edema. However, in this case, the patient is pregnant. That is for pregnancy of 4 months. So how are we going to treat this patient? So what does the guidelines say? So in the guidelines, there is no clear management. If the BCVA is good, we might choose to observe the patient, since we know that pregnancy is a temporary condition, and there has been observation that the diabetic macular edema in pregnancy can resolve after the pregnancy has ended. However, if the BCVA is worsening, then in such cases we would not be choosing anti-VEGFs, and we would be going ahead with intravitreal steroids, as anti-VEGFs are contraindicated in pregnancy. Also, another important thing that we should keep in mind is that if we are giving anti-VEGF injections to a patient and the patient wants to conceive, then we should counsel them that they should not conceive for at least 3 months after their last intravitreal anti-VEGF injection. So to conclude, center involving and non-center involving DME have different treatment options. In such cases, visual acuity assessment is important, and if there is center involving DME, then anti-VEGFs are always the first line treatment. We should know in cases where when they are resistant to the anti-VEGFs, then we should know when to switch these agents, and to which agent we should switch, that should also be known. So surgically, vitrectomy also has a limited role, and we should also know how to manage diabetic macular edema in certain special situations, for example pregnancy. Thank you.